All right. Good afternoon, everyone. A special thanks for coming. Welcome to the third Latin American teleconference. My topic is when a normal cholesterol level is not normal, exposing an unusual presentation of familial hypercholesterolemia. My name is Jelani Grant, and I'm a second-year internal medicine resident. A special thanks to Dr. Orringer, Dr. Forghani, who's tuning in, Dr. Bosire, and Dr. Colombo on our expert panel. So the objectives of my presentation today is to review the diagnostic criteria for familial hypercholesterolemia, to review the coronary artery disease risk associated with FH, discuss the role of cascade screening and genetic testing, provide guideline-based recommendations for treatment, and review indications on when to refer to a lipid specialist. So we had a 23-year-old asymptomatic Caucasian lady who came into the lipid clinic, and essentially her concern was, a couple of years ago, I was told I had an elevated cholesterol. It was around 200. I have a family history of high cholesterol and premature coronary artery disease. What are my risks, and what should I do? A family history is significant for a mother who was diagnosed with severe hypercholesterolemia, a 30-year-old brother with severe hypercholesterolemia, a maternal uncle with total cholesterol levels between 400 to 500, all of his children which had elevated cholesterol levels, and one of his sons unfortunately died at 17 from an MI. There was concern for consanguinity. We weren't sure if the wife was an extended member of the family. She briefly smoked 3 cigarettes per day, but no other ASCVD risk factors. A physical exam was normal with no corneal arcus or tendon xanthomas. Laboratory testing. On initial presentation, 2 things stood out. Her total cholesterol was 228 and LDL 148. Her triglycerides, VLDL, HDL were all within normal limits. We did a lipoprotein A level, which was elevated at 143. Secondary causes of elevated hypercholesterolemia were ruled out. Her TSH was normal. A basic metabolic profile was normal. Liver function studies were normal. Urinalysis normal. So the question is, has this patient escaped the diagnosis of familial hypercholesterolemia? Just a quick overview. It's usually an autosomal dominant genetic disease. Typical findings are very high LDL cholesterol, more than 190, which our patient did not have. A family history of severe hypercholesterolemia, plus or minus premature CAD. Corneal arcus or tendon xanthomas on physical exam. Premature CAD, and if untreated, life expectancy is shortened. I decided to go through the main diagnostic criteria for FH, and as you can see worldwide, there's a lack on the consensus in diagnosing FH. In Northern Europe, they mostly use a Dutch lipid clinic criteria, and this has been more specific to a Scandinavian population. They look at the LDL cholesterol, clinical signs, family history, and gene mutations. The Simon-Broom criteria is mainly in the UK population, and again, they look at the total cholesterol, LDL cholesterol, and clinical signs of premature CAD. They go from definite to possible, but this is a UK-based population. And lastly, the American Heart Association criteria. So there's a clinical and genetic criteria for diagnosing FH, and we look at the LDL cholesterol levels, family history, or gene mutations. The drawbacks in each one is the Dutch lipid clinic criteria and Simon-Broom. It emphasizes on physical findings, but the sensitivity is reduced. The American Heart Association has a reduced specificity on diagnosing FH. Cascade screening. It examines the family history, physical findings, and lipid panels in first, second, and third degree relatives. It's cost-effective in finding cases. However, it's time-consuming, and it provides challenges based on insurance status. The rationale for genetic testing. Physical findings or family history of premature ASCVD are present in only a minority of molecularly defined FH patients. The family history may be unreliable due to decreased penetrance of the gene. The family history may be unavailable, and the LDL cholesterol is actually less than 190 in about 45% of molecularly defined FH patients. 27% have an LDL cholesterol of less than 130. The clinical value of genetic testing. It provides prognostic information. It promotes initiation and adherence to lipid-lowering therapy, and it serves as a basis for more effective cascade screening for case finding. The limitations. The absence of a monogenic abnormality does not exclude FH. It may result in influencing insurance premiums and employment, and it may affect family dynamics and relationships. The expense of testing has also proven to be a limitation. Would you consider genetic testing in this patient? I wanted to just review 3 of the most common causes of FH. So you have the LDL receptor gene mutations. You have the ApoB gene mutations. ApoB is a ligand on the LDL particle which binds to the LDL receptor. And PCSK9 gain of function mutations. So PCSK9 essentially works by enhancing recycling of the LDL receptor. So a gain of function mutation leads to increased LDL particles. How high is CAD risk in patients with FH? This study, which was published in JACC in 2016, looked at approximately 1,300 patients. The LDL cholesterol was more than 190, and only 1.7% of these patients actually had FH-causing mutations. They also compared LDL cholesterols more than 190 in patients who did not have FH mutations, and LDL cholesterols of more than 190 in patients who had LDL cholesterols. The former, the CAD risk or the odds ratio, they were 6 times more likely to have ASCVD. And in patients who had gene mutations, they were 22.3 times more likely to have ASCVD. So it shows that in the presence of having a mutation, your risk of CAD is increased just by having this mutation. I went back to the family findings. So our patient had no physical findings. Her initial LDL was 142, and she had the same LDL receptor mutation as both mother and brother. The mother on exam had corneal arcus, tendon xanthomas, and her initial LDL was 199 on a PCSK9 inhibitor. Her brother, who was 30, had no physical findings, and his initial LDL was 232 with the same LDL receptor mutation. Why did this patient with heterozygous FH have only mild hypercholesterolemia? One of the things we thought about was cholesterol levels usually track upward with age. Here we have a young lady who's very physically active. She exercises for an hour and a half daily. There could be incomplete penetrance of her FH-causing mutation, or there could be the concomitant presence of a small LDL lowering mutation. Which FH patients are at the highest risk? So there's a Spanish familial hypercholesterolemia registry, or the Safe Heart registry. They essentially looked at patients who had molecularly defined FH on a statin and ezetimibe. They compared their risk factors, and so they sought to see if it was associated with increased risk of ASCVD. Most of the variables on this table we're mostly familiar with: age, male sex, history of ASCVD, high blood pressure, obesity, and these are proven risk factors for ASCVD. The one thing that stood out was the lipoprotein A level has also been proven to increase the risk of ASCVD, which we've not been using regularly in practice. A little bit about lipoprotein A. It's similar in makeup as plasminogen, and it competes with plasminogen for fibrinolysis. So because it competes, it indirectly inhibits fibrinolysis, and it works at the site of plaque rupture, causing turbulent flow. So the risk of MIs, ischemic strokes, and aortic valve stenosis are increased. The 2018 American Heart Association guidelines for treatment of severe primary hypercholesterolemia. You begin with a high-intensity statin, aiming for more than 50% LDL reduction. If the LDL cholesterol is still more than 100, we add ezetimibe. And if it's still above 100 on a high-intensity statin and ezetimibe, you can consider adding a PCSK9 inhibitor. When to refer to a lipid specialist? Those with the inability to tolerate a high-intensity statin, those with an LDL cholesterol more than 100 despite being on a maximally tolerated statin and ezetimibe, and younger patients just to reinforce understanding of prognosis and disease process. Those with a strong family history of premature CAD, and those being considered for PCSK9 inhibitor therapy. So in summary, consider diagnosis of FH in patients with severe hypercholesterolemia and family history of early CAD. Consider the diagnosis of FH in family members of patients with established FH regardless of the cholesterol level. In patients with FH, do cascade screening whenever possible, and especially in younger patients, consider genetic testing. Treat primary prevention patients with FH to achieve an LDL cholesterol of less than 100. So based on my presentation, I invited Dr. Orringer, Dr. Bosire, Dr. Colombo, and in terms of dealing with this patient, initially, I wanted to ask Dr. Orringer, when coming up with guidelines for hypercholesterolemia or the treatment, what things do you usually consider when recommending how we treat these patients?
Well, the first, we'll make sure this is on. Are we on now? Are we on? No? Yes. Okay. Maybe this will work now. Okay. All right, so first of all, I want to compliment Jelani on that terrific presentation. It really got to the crux of this whole issue of hypercholesterolemia. One of the first things we need to remember is that when a patient presents with very high cholesterol levels in the clinic, we are not going to immediately assume that they have familial hypercholesterolemia. And in fact, most such patients do not have familial hypercholesterolemia, but have multiple small effect gene mutations in addition to more than likely an atherogenic diet. You put all those together, and most of those patients actually turn out to have so-called polygenic hypercholesterolemia, not a single monogenic mutation that's responsible for the diagnosis. But whenever a patient presents with an LDL cholesterol greater than 190, we always, first of all, like to confirm it on a repeat blood specimen. If it is confirmed, the next thing that we do is consider secondary causes. So at the very least, one obtains a TSH. You obtain liver function studies in the rare patient who has obstructive liver disease as the cause of their severe hypercholesterolemia. You also obtain renal function studies, and particularly looking for nephrotic syndrome, so you get BUN creatinine and urinalysis, since nephrotic syndrome may be associated with very high cholesterol levels. The vast majority of these patients do not have those abnormalities, and therefore you're left dealing with the very high risk for premature coronary disease that these patients have. So the way that we do that first and foremost is to remind them that despite their very high cholesterol level, that dietary therapy is always important. A reduction in saturated fat and cholesterol intake, and it's important to go through with them what the dietary sources of saturated fat are. So primarily we look at fatty meats, processed meats. We look at 2% or higher dairy products. We look at butter, cheese, and a rich source of cholesterol is egg yolk. And we talk to those patients about reducing those dietary components. In addition, once we've done that and we advocate regular cardiovascular exercise, most of these patients will still require drug therapy. And once the LDL cholesterol is greater than 190, we then usually talk to them about statin therapy. And when we initiate statin therapy, it's high intensity statin. So it's Rosuva 20 or 40 or a Torva 40 or 80 as a good first step. Our goal is to see at least a 50% reduction in LDL cholesterol. Now, these recommendations were based upon very carefully vetted studies that have been done in the literature. It's important to recognize that there have been no prospective studies in the literature where you take patients with severe hypercholesterolemia and treat them with a statin versus treating them with placebo. It's not felt to be ethical to do so. So we've had to do the best that we can using largely observational studies, which have supported the fact that those populations that have lower LDL cholesterol levels are associated with lower risk. Those who have very high LDL cholesterol levels are associated with high risk. And those populations who take statins and lower their LDL cholesterol have a lower risk over time. So when I start such a patient on treatment, I'm always talking to them about the reason that they are receiving treatment. And the reason they're receiving treatment is because treatment reduces the risk of heart attack and stroke. I try to de-emphasize the fact that we're lowering cholesterol because most people have no idea what that means. They understand when you tell them that I'm giving you a heart attack and stroke preventing medicine that I want you to take every day. Well, can I take it every other day? In fact, there's no day where it's less important to prevent you getting a heart attack or stroke. So I always emphasize when I start a statin on such a patient that I'm giving them a treatment that is specifically directed at reduction of heart attack and stroke risk. When I see younger patients, I'm more inclined, whenever possible, to have them consider genetic testing, in particular because there are two major reasons. Number one, we know that those who have monogenic mutations have a much higher risk over time of developing ASCVD, so that raises your antennas that they may be someone you'd really want to watch carefully over time. And secondly, I want them to have that information when they're considering family planning, because if they have heterozygous familial hypercholesterolemia, 50% of their offspring are going to have this disease, except if they happen to marry someone else who has familial, who has heterozygous FH, in which there is a 25% chance that they'll produce a homozygous FH patient. So it is very important, especially in younger patients, that when patients are able to do so, that they receive genetic counseling. And finally, all of these recommendations were vetted when we wrote the 2018 cholesterol guidelines. There's excellent information in that document about familial hypercholesterolemia and management, and that information kind of is summarized in the thoughts that I just provided.
All right. Thank you, Dr. Orringer. We also have Dr. Forghani, who's a clinical geneticist who's tuned in. I'm not sure if I'm able to ask her questions if she isn't here.
Yes, Dr. Grant.
Okay. So Dr. Forghani, my main question is, which patients do you consider genetic testing in, and what are the main concerns or problems you have when doing genetic testing in patients with suspected FH?
Okay. First of all, thank you for this great teleconference and considering inviting us. Hopefully we're going to have more similar programs to involve genetics with other specialties. So before I answer your question, I just wanted to mention something that penetrance and expressivity of hypercholesterolemia. There are two different subjects. Penetrance, for this particular case, could be age dependent. I agree with Dr. Orringer that because of lifestyle, she may have not presented the disease. Penetrance of the disease is like on and off switch. So she may not, we know the penetrance for LDL receptor better than other mutations, and that is about 90%. It's really high, but expressivity of the disease can be quite variable. So this could be a milder presentation that we may see later in life, or it could be part of that 10% low penetrance that she may not ever present the disease. So I can hear myself, and that's a little bit distracting, but I try to continue.
Sure.
So can you repeat your question? I'm sorry.
My second question was, what challenges do you face when counseling patients on genetic testing and recruiting family members?
Okay, the most important part of it, Dr. Orringer mentioned that it's very important that the prevalence of this disease is really high. It's about 1/200. And so it's not very uncommon that you find your patient get married to another person who is a carrier of one of these. I have to add that we are learning about more and more genes that can cause monogenic causes of hypercholesterolemia. So, and having two mutations, not even in exact same gene, could cause more severe form of familial hypercholesterolemia. So it is important when you detect a proband, counsel them about possible 25% having a chance of having a homozygous case, which if you mentioned about the family history about your patient that there was a 17-year-old with MI, did I hear it right?
Yeah. Yes, that's correct.
That sounds to me very much like homozygous. So it is important to counsel them on that the partner, if we detect a mutation in 1%, the partner get tested. How it's gonna affect the fetus, we don't have enough information. There has been cases reported in homozygous patients that they have not been on apheresis, and their cholesterol level have been at 500, and their fetus has been healthy with no problem. But I think this is an area that we need to do more research. Since most of the people are going to be heterozygous, this is not going to change significantly the family planning unless the father, if one of the partner has the mutation, the other one has it too. So we can do the prenatal diagnostic test to find out if the baby is homozygous or not. But a few articles that I have reviewed on fetuses that their mother had been affected, homozygous with hypercholesterolemia, the fetus didn't have any particular phenotype, specifically prenatally. So we are gonna explain to the parents that they have to be tested, and if the baby is homozygous, they may develop complication later in life. But I haven't had any cases that they required a specific counseling for prenatal management or basically the effect of the mutation in the fetus.
Okay, thank you.
Yeah.
Dr. Bosire, oh, sorry, continue.
No, I just wanted to add that previously we were only doing the test on 4 genes, and now they are more mutation. There are more genes and new mutation have been introduced. There was one question if ABCG8 can affect the presentation in the daughter, like basically phenotype in daughter. We don't know how these genes are talking to each other, and apparently daughter and the mother, they had the exact same mutation. We are learning about polymorphism that actually increases the activity of ABCG8, which is beneficiary to decrease the cholesterol. But if they both had exact same mutation, I would say that there are probably more modifier genes, or it has to do something with the penetrance of the disease that we are hopefully learning in the future. Thank you.
Gotcha. Thank you so much. Dr. Bosire, my main question is, especially as we are internal medicine residents, we see a lot of these cases in clinic, and I for myself, probably if I saw this lady with an LDL cholesterol of 130, I would have bypassed it. So my question for you is, how often do you see patients with severe hypercholesterolemia? Do you feel comfortable in your practice treating these patients? And when would you decide to refer to a lipidologist or cardiologist?
I think I see a lot more patients. I think I do see a lot of these patients, and they're quite hidden. This particular case is very rare because the patient comes in with actually a family history and a concern. And that's something oftentimes that we do, especially within primary care, because I'm family medicine, is that, getting the entire history and asking the questions about that in regards to saying, hey, my father passed away. I'm 23. When did your father pass away? 40. Finding out exactly, what happened, because you don't get this information up front. And that's part of the reason why, as primary care providers, having patients actually being seen, more than once a year, and making sure that you continue to dive into that history, because things come up. You see patient 1 year and they may not have anything, and you see an LDL that's on this patient and you say, okay, I can go forward. But then you see them the following year and you ask them the same question. So we update your history. What's going on? Oh, well, my uncle passed away and I went to the family funeral and I found out A, B, C, and D. And so that's very, very important that we do that. Our patients, again, do not give us the histories that we often need, and that's why we need to continue to ask. I'm very fortunate to work with Dr. Orringer in regards to when do I actually refer. So normally I would get a patient that I would see at an LDL of 190, and of course everybody's eyebrow will go up for that. And so from that standpoint, actually talking to that patient, counseling them, looking at their ASABD risk factor and saying, hey, you're a candidate for a statin at this time. And talking to those patients can be very, very difficult. As Dr. Orringer mentioned, in terms of saying that we're not lowering your cholesterol. My job here is to reduce your risk of having a heart attack or a stroke. Patients, because they've what's out in the media is that, statins are going to affect me. I'm going to get Alzheimer's disease. My memory is going to be affected. Things of that nature. I'm going to get myalgia. That's a very small percentage of patients that actually get that. We know that we start low and we go high on our statins. When those patients have actually done the work and they've tried, oftentimes if I do put them to ezetimibe, they have some resistance. That's kind of when I bring in the lipidologist for that, to kind of get that. Because what happens is because you have a relationship with your patients, is that they've only heard the speech from you. And sometimes you need someone else to actually be in your peanut gallery and say, hey, no, what she's talking about is really true. So, who better than have Dr. Orringer in the next pod come over and say, hey, this is what's going on. So then oftentimes, they will drink the Kool-Aid and say, okay, then I think I might go forward. And so from that standpoint, that's when I feel that once I've actually exhausted, the ezetimibe, then I tend to send the patients over to the lipidologist. So, and we talk in the hallway about our patients as well. So I think my antennas are up a little bit higher than most.
Okay. And Dr. Colombo, I've seen a lot of patients with you, and my main question is, in patients less than 45 or young patients, other than familial hypercholesterolemia, what does your usual workup for coronary artery disease or MIs or ASCVD in these patients entail?
Thanks, Jelani, for that. Can you guys hear me? It's working. Okay. Thanks for that question, Jelani. So firstly, we have to make the diagnosis of an MI if that's what you're worried about, and that involves proving that there's myocardial injury with an elevated troponin, usually over 99% of the reference interval, in association with one of the other factors, whether it's symptoms of angina or ischemia, EKG changes like pathologic Q waves, or an echo that may show regional wall motion abnormalities or loss of viable myocardium. Once we've made that diagnosis, you have to exclude one of the most common things. In younger patients, coronary artery disease from atherosclerosis is not as common, but it's still a concern, especially as people are more obese and having complications of diabetes and hypertension for longer at a younger age. So typically, when we have a patient with an MI, whether a non-STEMI or clearly a STEMI, they should probably eventually get an ischemic evaluation with a cardiac catheterization, coronary angiography, to prove, yes, they do have that 99% blockage in that right coronary artery causing an issue. Or no, in fact, they don't. And that's where things get interesting. So we see a patient where we would have expected to see an atherosclerotic plaque that was significant, 80, 90, or even totally occluded with a thrombus, but we don't. And then we have to think a little bit more. And those patients, we actually have a categorization for them called MINOCA, or MI without or no obstructive coronary artery disease. It's an increasing area that's been researched. It's actually not just the diagnosis of a specific condition, it's actually a spectrum of disorders that fall under that category. And patients there may still have atherosclerosis. One of the common causes of MINOCA is actually plaque disruption and erosion, but in a plaque that was not, let's say 90%, but rather 40 or 50%. And that plaque eroded may have caused a transient thrombus that by the time they took a look with the coronary angiography, because maybe they received antiplatelet therapy or heparin prior to that, had already dissolved. So that's actually one of the things we should be paying attention to. That's very hard to detect with coronary angiography by itself, because you can see that there's a plaque there, but you may not actually see the abnormalities in the wall. We actually have a type of study that we can do in the cath called OCT, or optical coherence tomography. It's not done super commonly, but it's almost kind of like doing a mini CAT scan, not so to speak, inside of the coronary artery. And you can actually look into the vessel wall and see what's going on there. Is there a vulnerable plaque with a thin cap, or is there a hematoma or something else? And that can sometimes help us look for other things that could be in this differential for an MI in a young person. That includes dissection, which can be spontaneous coronary dissection in young women with other risk factors, probably not in these patients. We also look for other things. We think about myocardial bridges and other causes of elevated troponins and chest pain. So it could be myocarditis. There's the concern for tachycerebral cardiomyopathy. That will, of course, be in a different setting with an echo finding that's more suggestive. But I think it's important that you realize patients that maybe they don't have FH, but they have risk factors. They may have either plaque disruption, erosion with minimal disease on coronary angiography, less than 50%. We also have this other entity called microvascular dysfunction, which is kind of this somewhat nebulous topic that is becoming increasingly recognized, where we have endovascular dysfunction at the microvascular level. We know that that accounts for probably a very large percentage of these patients with MNOCA, with all the typical risk factors of diabetes, hypertension, smoking. And those patients we know actually benefit from being treated with medical therapy. So what's tragic about that is that many patients will get an MI. They may be diagnosed with no significant obstructive disease, but they have multiple risk factors for microvascular dysfunction, and they don't get treated for that. They don't get their aspirin, they don't get the statin and the beta blocker, which studies have been showing have actually shown to improve outcomes in those patient populations. The workup for the MNOCA is not easy. It requires a few steps. One is to look again at the coronary angiography and make sure that something wasn't missed. Actually, people may undercall a lesion that was not seen. And then after that, it's looking at the case more deeply. Is it something I need to look at with intravascular ultrasound or like OCT? Do I need to do an MRI to exclude myocarditis? Do I need to look at that echo and again and make sure I didn't miss a cardiomyopathy? So it's a very wide topic and a lot of things you can do. It's very interesting and more data is to come for that.
Right. Thank you, Dr. Colombo. And does anyone else have questions? Well, not for me, but for the panel.
I have a couple for Dr. Orringer. The first one is, can you please comment when we are evaluating lipid panels on the value of ApoB? It is my understanding, and please correct me if I'm wrong, that when we look at an LDL, it might be high or maybe not so high, but it's not so much how much of bad cholesterol you have, but also how are those lipoproteins? Are there the smaller kinds that are supposedly at this convey a higher risk? And how is that ApoB something that might be helpful to differentiate that, and do you use it routinely? And the second question is on patients with familial hypercholesterolemia with high LDLs, especially in the female in reproductive age, where they have that LDL above 190, but they're planning for family. And our mainstay treatment is statins, which are at least theoretically not safe in pregnancy. So how do you approach that?
Okay, well, so thank you for those questions. Let me first talk about the second question, because I think it's pertinent to.
We can't demand to use your mics. It's just this space at the other.
Okay. I first want to address the second question, which specifically relates to the issue of what do you do when you have a young woman who has an LDL cholesterol of 190 or greater, and you know you've ruled out secondary causes, you know she has to be treated with a statin. The answer is, I always talk to the patient, document in the chart that they are on at least one highly effective form of birth control. And I tell them that I will not treat them with a statin until I know that they're on that, until they can tell me that for sure they are protected. And so step number one is you have to have a contract with your patient that they are going to use reliable birth control. And I also tell them that if you are between birth control methods, I would sooner you not be on the statin until you're solid on whatever your birth control method of choice is going to be. So, and interestingly, if you go back to looking at the data on teratogenicity of statins, it's kind of shaky to begin with. It's not that strong, but there have been enough cases that people are concerned about it. There have been no prospective studies showing that statins are clearly teratogenic, but there's enough there that the FDA has suggested that we not use statins in women of the childbearing age without good birth control. So that's point number one. Point number two, what about these other tests, these fancy tests, ApoB and these different kinds of profiles that give you thousands of different pieces of information about patients? And the answer is, in the vast majority of patients, you can get all the information you need from a lipid profile and, when necessary, an Lp(a). ApoB represents a homing mechanism on an atherogenic particle that drives it to the LDL receptor. And there's one ApoB particle per atherogenic. There's one ApoB molecule per every atherogenic particle. So someone said, well, maybe it's a better way of assessing risk. But when we've compared ApoB to non-HDL cholesterol, which is simply taking total cholesterol minus HDL cholesterol on a regular lipid panel, the two have literally identical predictive information in terms of risk. There are certain populations in which that may not hold, like diabetics or patients with chronic kidney disease, metabolic syndrome patients occasionally like that. But the bottom line is, you can get just about all the information you need by simply taking your regular lipid panel and taking total cholesterol and subtracting HDL cholesterol. And that'll give you the so-called non-HDL cholesterol, which actually is a very good way of predicting how many atherogenic particles are present and whether the patient needs more aggressive treatment. So if you have a patient with elevated triglyceride levels and their LDL cholesterol is say 75 or 80, but their non-HDL cholesterol, which is total minus HDL cholesterol, is above 100, that means that patient may need more aggressive treatment. So we tend not to use these fancy panels. They cost patients money, and in the great majority of cases, they don't provide any substantial additional information. On the other hand, lipoprotein A, this special kind of particle that Jelani talked about, is actually an extraordinarily important risk factor for both ASCVD and for the development of progressive aortic stenosis. Elevated lipoprotein A levels are actually present in about 20% of the population. And by the way, it's important to point out with regard to Lp(a) that there are different norms for Caucasians versus African Americans versus those from East Asia. So it's important to know what the information is, who the patient is, before you interpret what a significantly elevated Lp(a) level is. But when the Lp(a) level in Caucasians is 100 nanomoles per liter or greater, that's considered significantly elevated. When it's greater than 150 nanomoles per liter in African American patients, that's considered elevated. So the bottom line is, you need to know what it is in the population that you're picking it out in. But clearly, it's associated with increased risk. Especially think of getting it in those who have strong family histories of early heart disease, especially in the absence of other risk factors. You might want to draw an Lp(a). And when you find it to be elevated, that's an indicator that you want to be more aggressive on your statin therapy, and you want to be more aggressive in terms of looking at their other risk factors.
Okay, thank you very much. A great presentation and discussion. A couple of comments. This patient has a relatively high HDL, so the non-HDL will be probably about normal, which is the title of the presentation. I wonder, in the risk stratification of this patient, the value of measuring inflammatory biomarkers such as C-reactive protein, you can comment on that. Certainly, Lp(a) is pro-inflammatory, so you have an added risk. And the second point is on the value of, you can comment on the value of measuring vascular calcification. So this patient may not be at the point of having a clinical event, but have evidence of subclinical atherosclerosis. So,
well, those are two great questions. And first of all, in terms of the HDL cholesterol level, and it's really great that I have the chance to do this. I want to dispel for you the common notion that high HDL cholesterol protects you against heart disease when a patient is sitting across from you. I've had countless patients come in to tell me that despite their very high LDL cholesterol level, they had a high HDL, so their doctor told them that they don't have to worry about it. And the fact is that in populations, high HDL cholesterol tends to be associated with lower risk. But in the patient sitting across from you, you know nothing about the cargo that HDL particle carries. It could be carrying all sorts of pro-inflammatory cargo, or the HDL cholesterol. The HDL particle may not work well in removing cholesterol from the arterial wall. So while it's important in populations, it may be deceptive for the individual. So I would eliminate the HDL part when you're talking to your patients, especially those who are telling you they don't need treatment from their very high LDL cholesterol because their HDL is high. So that's point number one. Point number two, we traditionally don't check. Non-HDL cholesterol can always be easily measured if you're good in math and can subtract one number from another. But in most patients with FH, triglycerides are normal. So when triglycerides are normal, HDL cholesterol is usually normal, and therefore we don't worry much about non-HDL cholesterol in patients with FH. Their risk is high to begin with. So that's usually not an issue. We do not tend to need to get inflammatory markers in these patients because regardless of whether they've got a pro-inflammatory or don't have a pro-inflammatory milieu, they've got so many LDL particles that they're at risk. And the reason that they're at risk is not because they overproduce these particles. They're at risk because their LDL particles have nowhere to go. They don't have enough LDL receptors. And as a result of that, the LDL particles can't go back to the liver to be removed from the body and therefore go into the tissues. So it's not, I mean, if they have a pro-inflammatory milieu, they will have it, but they've got so many LDL particles that that is what is driving the great majority of their risk.
Thank you, Dr. Andrew.
Yeah, vascular calcification. So there was a recently published study in JACC cardiovascular imaging showing that patients who had, patients with familial hypercholesterolemia who had elevated coronary calcium scores had a higher risk than those who did not. But the fact of the matter is that we do not routinely recommend getting coronary calcium scores on patients with familial hypercholesterolemia simply because the risk is either extremely high or extremely, extremely high. And so under those circumstances, the treatment of choice is still the same. Start with a high-intensity statin to lower LDL cholesterol by at least 50%. If you don't get there with that, you add ezetimibe, and if you don't get there with that, then you might want to consider discussing with the patient the use of a PCSK9 inhibitor. So the bottom line is the likelihood of cardiovascular events in these patients is a function of two things: the height of the LDL cholesterol and the duration of time that their endothelium is exposed to that excess of LDL particles. So whatever you can do to reduce that reduces their cardiovascular risk.
Okay. Thank you, Dr. Orringer. Any more questions? All right. Thank you, guys. Thank you. No problem. Sure. Can you help me with this? So,
Oh, thank you. It was great. So was she started on statin?
she was.
She was? Thank you so much. We're going to take a picture. It was a pleasure. Thank you so much.
Thank you.